This portion of CardioSource video news coverage of TCT 2010 is brought to you by Medtronic.
Good morning, I'm Dr. Randy Martin, and welcome to CardioSource Video News. TCT 2010 wraps up today, and it's proven to be a great mix of breaking clinical trials and medical information for all the attendees to take home and implement into their practices. Now, for a recap of the conference highlights, Dr. Jeff Popma has been kind enough to join us. Jeff is the director of the Interventional Cardiology Program at Beth Israel Deaconess Medical Center in Boston. Jeff, thanks so much for joining us for sharing the insights. There seemed to be a lot of buzz about the partner trial and its implications. So what's your take on that?
Well, first of all, I think we all want to share in congratulations to Marty Leon and Craig Smith and the partners investigator to complete what has to be viewed as a transformational trial. I think that there are probably two or three very key messages for the general cardiologist as a result of this. There's differences in technology and how we do things and all that sort of thing. But really, when we come down to the management of patients, elderly patients, with critical aortic stenosis, the clinicians are oftentimes caught not knowing what to do. And I think the first lesson that we learned out of Partner was that the prognosis of a patient with symptomatic severe aortic stenosis who has comorbidities that make them not suitable candidates for surgery is abysmal. Yeah. And when we talk about mortality rates at 1 year of over 50%, with optimal therapy that in over 80% of the patients included balloon valvuloplasty, we understand that this is a diagnosis, as was discussed yesterday, that's worse than many cancers are.
It's interesting. I'm thinking every time there's a talk on AS, you see that old 50-year-old slide of all this stuff. So now the slide could be updated because it really is a worse prognosis.
Or maybe it doesn't need to be updated because nothing's changed.
But adding in the concept that balloon valvuloplasty really. Yeah. So anyhow, go ahead.
No. So I think, and the piece of this is that we all believe that by doing balloon valvuloplasty, by optimizing medical therapy, patients in the partner trial, 20% of them had a pacemaker to start, so you know that the rate rhythm issues were controlled, that their prognosis was just not good. And their rehospitalization and all-cause mortality rate was over 70%. Now, what's
that mean for the clinician?
Well, what it means for the clinician is a couple different lessons. First of all, there were over 3,000 patients with severe aortic stenosis that were screened. And of those 3,000 patients, about a third of them actually got randomized in the trial. And I think what we have found is that oftentimes when we see the patients and they're in their mid-80s and they're basically okay, they may actually be good candidates for surgery. And our heart surgeons have really stepped up to the plate and done very, very good surgery in these high-risk patients and gotten great outcomes. And I think there was a lot of discussion at this meeting about how the outcomes have improved. Okay. So the first thing, we have to get them in. The second one is I think that the final conclusion of the accompanying New England Journal article is that percutaneous valve therapy has really become the standard of care. And we have to convince the FDA of that, of course, but it's really become the standard of care. So I think the message to the community cardiologist is, if you have a patient that has critical aortic stenosis, it's great to get a multidisciplinary evaluation with a heart surgeon and with an interventionalist and some non-invasive testing to see if they're candidates for alternative therapy.
You make a really valid point. This is a dismal prognosis. We have an aging population, certainly inflammatory markers, lots of people out there with the AS, so we know it's dismal. So you're saying really look at this and know there's things we can do for these patients. Don't just push them off to the side.
Yeah, it's estimated that from several different published series, primarily in Europe and elsewhere, is that about of the 60 to 70,000 aortic valve replacement surgeries that get done in the United States each year, there's probably another 30 or 50% of patients who have high risk factors and never see a surgeon. And it's not that they wouldn't be candidates for operation; it's just that they don't get referred in for evaluation. Now, oftentimes, when you assess the risk and the benefit, how much is one of our surgical friends, Mike Deeb, says, how much is the patient going to hurt as a result of their operation? You can make the decision that maybe duly well off and alone. But what we've learned is Once that decision is made, it's about a 50% mortality rate at the next year.
Spencer King and Peter Block and I were talking, and Spencer, I think, was the guy that made the point that this also shows, and I think you just said it, that valvuloplasty, which we used to think was a bridge, gave people some time, really doesn't look like optimal care. Is that right?
There is a subtle piece to that, and that yesterday we heard from Tuscu the outcome of patients who were in that medical therapy group, and we saw the outcome of patients of those who got valvuloplasty and didn't get valvuloplasty in the medical. Now it's not randomized,
right? I understand.
But there was a suggestion that they did better with valvuloplasty.
Okay,
but compared to the percutaneous valve therapy, that's the incremental step forward. So I think when left with a patient who does not have suitability for inclusion in one of the percutaneous valve programs, that valvuloplasty is palliative, but it's not really going to change the ultimate prognosis tremendously.
Just before we go to break, do you think that this is going to change the management of patients drastically, the way we approach it?
Well, I think as we look at the typical partner patient that was involved, and I think as we're building our core valve trial, we've learned so much from the partner trial, but these patients were extremely ill.
Right.
And they did extremely well. A 5% 30-day mortality with a percutaneous aortic valve in this population. So the standard is going to change. We got regulatory processes to go through, additional studies to get done. We're launching more studies with the Medtronic core valve trials. Soon as we work through the FDA regulatory processes. We've got more trials that are around the corner, but at least right now, the data for these ultra sick, extreme risk patients is that with percutaneous valve therapy, there's about a 5% mortality. That sounds pretty good.
That's pretty good. You piqued my interest on a couple things. I'm going to come back to you just after the break. So we're going to go to break right now. We're going to have much more for you in just a minute. Stay tuned.
Medtronic proudly introduces Integrity BMS, now available in the U.S. Visit MedtronicStents.com for more information.
This is CardioSource video news coverage of TCT 2010.
Welcome back. We're again joined by Dr. Jeff Popma, who's kind enough to be sharing with us his overview of TCT 2010. Jeff, you just gave us some good insight about lessons we've learned from the partner, but I was intrigued. You and I were talking earlier. You said on all these panels, the surgeons were interacting with the cardiologists. This really has sort of opened up a collaborative effort that's, I think, unique in cardiology.
Well, it is. I mean, and I think TCT is a perfect manifestation of that because there's so many topical issues that relate to both heart surgeons and to interventionalists. Not only was there a boot camp for heart surgeons that wanted to learn how to do that. That was pretty good. There was tremendous discussion on the percutaneous aortic valve piece, which we have active participants with that. And I think the other piece that was so interesting here was there's a lot of talk about how to manage patients with multivessel disease. We have new trial and refinements of the trials, but now heart surgeons and cardiologists are really working together to come up with appropriate management strategies for patients with multivessel disease.
You look at the oncology programs where you have oncologists, cancer surgeons, et cetera, et cetera. For the patient, the concept of the surgeon and the interventionalist and even the humble, non-invasive cardiologist working together to figure out the best management really is the best care.
Well, there's two particular aspects I think that were highlighted here at this meeting. One is that there is an ACC-STS collaboration. CERT, Bill Weintraub and Fred Edwards are the principal investigators for that, which has been funded through a GO grant to interrelate the STS and the CAF-PCI databases, integrate that with CMS outcomes databases, and start looking at some of these outcomes in matched patient populations with appropriate propensity score matching. And then we had a lot of discussion about the new European guidelines for heart surgery, and with some very specific guidelines to clinicians about how to differentiate management in patients with multivessel disease.
When you were talking about the collaboration, I'm thinking about hybrid ORs, but it's really, and that's certainly a unique effort, but you're really talking about valve clinics that could be staffed, or this concept. And tell me, as you look at multivessel disease, so where are we going with that, the management of the patient with ischemic heart disease?
I think the guidelines, I'm going to encourage everybody to look at the guidelines, because they were really done in collaboration with what the ACC guidelines are, but there was a change in our recent PCI guidelines where the left main came off the back burner. So no longer is a class 3, it now is a class 2B, but that means it's randomizable at that point in time. And with the new guidelines from the European heart surgeons, it's actually given us fairly definitive criteria about what's good and what's not so great, and relating that with the ACC. And the bottom line for the clinician is that simple 3-vessel disease that can be treated with complete revascularization of PCI is probably fine to go ahead and do that. Complex multivessel disease with lots of total occlusions where PCI can't fully revascularize a patient, probably surgery is the way to go. The gray zone that's left is this left main disease with non-complex disease. And what do we need? We need a randomized trial. A lot of discussion about the Excel trial, which will do that here. Greg Stone, Patrick Sorois, and surgical colleagues on both sides from the Cleveland Clinic and the Thorax Center are going to lead this trial. And that's going to give us a randomized study in patients with left main disease about whether PCI or heart surgery is the appropriate way to go.
So really some unique developments. Not only, as you look at this, so what's the non-interventional clinical cardiologists need to be thinking about with ischemic heart disease?
Well, I think it's key. It's ischemic heart disease, right? It's not asymptomatic disease.
Right.
And so I think the message to the clinician is if there's no demonstration of ischemia, then what we do is want to maximize all the primary and secondary prevention things that we do to stop atherosclerosis. It makes perfect sense. But if the patient is limited symptom limited with angina, they have moderate areas of ischemia on their stress testing, then at least it behooves us to know what the anatomy is. And I think that's been lost in some of these. It's not necessarily a CT angio anatomy, it's a cath anatomy. Because then we certainly understand, and many times the answer is medical therapy. Many times the answer is, from Courage trial and otherwise, that we should just do medical therapy in these patients. But many times, with critical stenoses and moderate areas of ischemia, we have to make choices about revascularization. And that's where the patients want to have the surgeons and the interventionalists talking to each other, and coming up with recommendations.
It really is an exciting. I've been doing this a long time. It's a very exciting time in cardiology, and I think you make some unique comments about the collaborative. We really are at a collaborative phase, and I think that's going to be exciting. Do you see us having multidiscipline clinics coming along?
Well, we do now. So certainly all the valve clinics have done that way. It's certainly in the aortic area. It's definitely going to move into the mitral space as well. We are now talking more about the appropriateness for revascularization, whether that should be done. And the real interesting piece of this fallout is that when we do start interacting and talking together, there's some patients, for example, not many, but some patients, where hybrid revascularization with a lima to the LAD and stenting in the other native vessels that are not suitable for bypass surgery is the way to go. And then we start talking about how we're going to time these procedures with our surgeons. They're pretty fun to be around. This is something we've really learned. We actually have a good time when we're with them.
I think you're exactly right. Well, listen, I really, really appreciate you sharing these oversights and really giving us a neat direction for the future. And that's going to essentially wrap up our coverage of TCT 2010. Now, we're going to be seeing you at the American Heart Association meeting coming up in Chicago this November. We'll have full coverage of that meeting November 14th through the 16th. I'm Dr. Randy Martin, and for all of us at CardioSource Video News, thank you for joining us.